Thanks, Gary. And I'm probably even going to overlap as a service provider with what Ken shared with the audience. Because as a service provider, we're still thinking of the same things about big data, about security, about interoperability, on how we can quickly provide services to large healthcare systems. One of the key things, and I'd say data, big data is huge. And I think as service providers and healthcare providers, we're going to be competing for the same set of resources in data science and data analysts. And we had the opportunity last year as a company to have a few major healthcare systems come in and talk to AMN. One was Vanderbilt University, Stanford Medical System. We also had Baylor Smith White. And they're emerging from their big EMR implementations of the Cerners and the Epics, and they do have devices connected to their networks. They have rich clinical data, they have patient information, and they really are standing there saying, their maturity level is rather low. What do we do with this? How do we extract that? How do we get rich insights to take action and optimize our hospitals into true businesses, right? With always patient care at the forefront. So we, as a supplier, really want to leverage the same thing on how can we get in and how do we add value. If we look, let's take it over to the workforce analytics piece of this and how we might look at the costs in healthcare. Labor constitutes about 50% of the spend in healthcare systems around the world. And so to optimize that, and I think Ken, you shared with me, to get to optimal levels, maybe you want to be in the mid-40s and how well you optimize that workforce. And that really can bring some savings to the bottom line, but can also have a dramatic impact on how you look at that and really in providing quality level practitioners out there the quality of care. So a little bit of background for me is I've been in the medical device, pharmaceutical, healthcare industry for a long, long time. And one of the biggest things being on the other side of the coin in a medical device manufacturing or distributor, class 3 medical devices, data and integrity and reliability of data has always been there. That hasn't left us at all. And it was always about traceability, reliability, security. And I remember back in the day, we would just secure a shared file folder system out on a network drive and have 2 levels of authentication to get to a digital record. And we thought we were really secure. But we also had to surround that with policy and training and other manual processes to be in compliance with FDA regulations around clinical and device data. Those same standards still apply today with PHI, HIPAA High-Tech, and how we look at information, right? It's just much more digitized. But I do want to put out there that policy and risk tolerance around that still needs to complement the digital world of information today. And that, I would say, is still rather inconsistent across healthcare systems, service providers. So interoperability, number one, I think is key, and kind of normalizing those standards and risk tolerances around data and security. We need to normalize that. I remember back in the supply chain days when 3M and Johnson, I was sharing this with Julie, 3M, Johnson & Johnson came together to form the Global Healthcare Exchange. And that really opened up the door for service providers and institutions to exchange and share data, information, products, services, you name it. But it really, that consortium set the standard to really accelerate interoperability between vendor suppliers and institutions. And I really believe I would put that out there as a big need in the healthcare space. And I know we're doing that with Health Information Exchange. But underneath that are just a huge fractured set of providers that still aren't interoperating very well today. So the other part of that, when we look at it from a workforce perspective, the skill sets of our practitioners and clinicians is changing. Primarily, we used to focus on providing workforce, clinicians to large acute care institutions. And now these practitioners or these clinicians are working all the way down to the home level. And that means that as they get themselves further away from those institutions, they have to interact with mobile devices. they have to be able to provide information in real time about that patient care. So security and mobility on how we, as a provider of these services and workforce clinicians, how do we get that back into the institution? So that needs to settle, and that needs to become a little bit more clear so we can, again, provide the right services. Interoperability. The other key one, again, is on, so the problem statements that I have, again, is inconsistent around standards, and they vary wildly. The ability for us to quickly place those resources and how well we can get credentialed packages and information about those clinicians to the healthcare system. And then also, that's about staffing, but how do we go in and apply data analytics and information on workforce optimization? It's still a huge challenge for us. And then how do we measure ourselves to stay ahead of the game and really bring cost and quality of care back in as a service provider? I'd say these three things are still front and center. They're very similar to what Ken shared with you. And again, I think these things intersect as a vendor-supplier relationship. And that's it.